Welcome. In this session, we'll be discussing the secondary open-angle glaucomas following vitreous hemorrhage, retinal detachment, and due to drugs, particularly steroids. Glaucoma following vitreous hemorrhage can be of two types, hemolytic glaucoma and ghost cell glaucoma, and both of them can coexist in the same eye. In hemolytic glaucoma, hemoglobin-laden macrophages obstruct the trabecular meshwork, and clinical features of hemolytic glaucoma include vitreous hemorrhage, red-colored cells in the anterior chamber, and reddish-brown coloration of the trabecular meshwork. In ghost cell glaucoma, due to vitreous hemorrhage, degenerated red blood cells block the trabecular meshwork. 2 weeks to 3 months following vitreous hemorrhage, the normally biconcave, pliable, and reddish-colored red blood cells lose their hemoglobin and become stiff, spherical, and tan or khaki-colored cells called ghost cells. And this degeneration of red blood cells are said to occur when these red blood cells are exposed to the vitreous. These ghost cells then enter the anterior chamber through a ruptured anterior hyaloid face, and being stiff, they obstruct the trabecular meshwork. I could not find a non-copyrighted image of ghost cell on the internet, so please look up on the web for a clinical photograph. Clinical features of ghost cell glaucoma include khaki-colored cells detectable in the anterior chamber, and the color of these cells as represented here in this diagram is very important to appreciate. Flare is minimal in ghost cell glaucoma, and these ghost cells can layer in the inferior angle to form a pseudohypopyon as shown here in this diagram. These ghost cells can also layer over a layer of intact red blood cells, and this is called the candy stripe sign of ghost cell glaucoma. The vitreous hemorrhage behind the crystalline lens also appears khaki colored with clumps of pigments which are formed by extracellular hemoglobin. Gonioscopy shows open angles, but layering of the angle with ghost cells can be detected, particularly in the inferior angle. The IOP will be found to be elevated, and this IOP elevation is often severe with corneal edema. Treatment of hemolytic and ghost cell glaucoma include clearance of the vitreous hemorrhage with vitrectomy and reduction of the IOP by medications and surgery as required. Following a regmatogenous retinal detachment, the intraocular pressure is usually found to be low as compared to the fellow eye due to exit of fluid from the vitreous cavity through the retinal break into the subretinal space. But in a few cases following retinal detachment, raised intraocular pressure can occur. In the Schwartz syndrome or the Schwartz-Matsuo syndrome, following regmatogenous retinal detachment, dislodged photoreceptor outer segments in the subretinal space enter the vitreous cavity through the retinal break and then pass into the anterior chamber where they block the trabecular meshwork. And the photoreceptor outer segments can be mistaken for a cellular reaction in the anterior chamber. And the raised intraocular pressure in Schwartz syndrome usually normalizes following surgical reattachment of the retina. Other possible causes of glaucoma coexisting with the retinal detachment include pigment dispersion syndrome, which tends to occur in myopic patients who are prone to retinal detachment, angle recession from trauma, which may also cause a regmatogenous retinal detachment, primary open-angle glaucoma, which has been found to be statistically associated with retinal detachment, neovascularization due to retinal ischemia, and following retinal detachment surgery. Some of these causes of glaucoma can have an angle closure component. We have discussed drugs which provoke angle closure attack in the session on primary angle closure, and in this session we will be discussing about drug-induced open-angle glaucoma, among which steroid-induced glaucoma is the most well-known. Prolonged use of steroids in any form, topical, periocular, intravitreal, inhaled or oral, can increase intraocular pressure by increasing the resistance to aqueous outflow through the trabecular meshwork. And steroids have been shown to increase deposition in the extracellular matrix of the trabecular meshwork and cause reduction of phagocytic activity of the trabecular endothelial cells lining the trabecular beams. And this phagocytic activity is important to clear the debris from aqueous humor so as to maintain the patency of the trabecular meshwork. Steroid responders are those who have a rise in intraocular pressure following exposure to steroids. And it has been seen that following 4 weeks of administration of topical steroids 4 times a day, 35% of normal population have an increase of intraocular pressure by between 6 to 15 millimeters of mercury, and they are called intermediate responders. And 5% of normal population have an increase of intraocular pressure by more than 15 millimeters of mercury, and they are called high responders. And more than 90% of primary open-angle glaucoma patients are high responders. And this is very important to remember when prescribing steroids to patients diagnosed to have primary open-angle glaucoma. And risk factors known to increase steroid responsiveness include, as we have mentioned, primary open-angle glaucoma or even a family history of primary open-angle glaucoma, very young or old age, myopia, type 1 diabetes mellitus, and connective tissue disorders. Rise in intraocular pressure can occur following weeks to years of chronic steroid use, and it depends on the route of administration of the steroid and the potency of the steroid. So close monitoring of intraocular pressure during steroid use is mandatory, and this is very important to remember. The extent of intraocular pressure rise also depends on the anti-inflammatory potency of the steroid and also the ocular penetration capability of the steroid preparation. Higher potency steroids such as dexamethasone, betamethasone, prednisolone, and difluprednate have significant potential to raise the intraocular pressure, whereas fluoromethalone, remexolone, loteprednol, and medrisone have a lower tendency to raise intraocular pressure. But some individuals are even responsive to these low potency steroids. A single injection of intravitreal triamcinolone can raise intraocular pressure for several months, and it has been estimated that following intravitreal triamcinolone injection, as many as 50% of patients develop raised intraocular pressure, 25% require topical ocular hypotensive therapy, and 1 to 2% require filtering surgery. Systemic steroids have a lower potential to raise intraocular pressure than steroids administered through any of the ocular routes. And Cushing syndrome patients who have high endogenous steroid levels may also have an elevated intraocular pressure. Before administering depot steroids such as periocular and intravitreal injections, response to topical steroids should be evaluated. And after initiation of steroid therapy, IOP needs to be rechecked. And one recommendation is the initial recheck of intraocular pressure should be done 2 weeks after initiation of topical steroid therapy and 1 week and 4 weeks after initiation of depot and oral steroid therapy respectively, following which IOP needs to be rechecked again at periodic intervals. In a patient with steroid-induced increased intraocular pressure or glaucoma, steroid should be withdrawn if possible. And following withdrawal of steroids, decrease of intraocular pressure takes similar or longer time than onset of raised intraocular pressure following initiation of steroid therapy. And even after withdrawal of steroids, some patients may have persistently elevated intraocular pressure. The intraocular pressure can be lowered with ocular hypotensives, laser trabeculoplasty, or filtering surgery in refractory cases. And in this situation, cholinergic agonists and prostaglandin analogs should be avoided because they are pro-inflammatory and may provoke inflammation for which the steroids had been administered in the first place. Refractory ocular hypertension following periocular steroid administration may require removal of the drug depot in the periocular region. In addition to provoking angle closure attacks, cycloplegics can cause raised intraocular pressure by an open-angle mechanism in pseudoexfoliation, pigment dispersion, and primary open-angle glaucoma. In pseudoexfoliation and pigment dispersion, mydriasis may cause release of pseudoexfoliation material and pigment granules. And in primary open-angle glaucoma, administration of cycloplegics may affect the permeability of the trabecular meshwork. Transient increase of intraocular pressure following anti-VEGF injections are common. and it has been observed that repeated anti-VEGF injections in the same eye can cause sustained elevation of intraocular pressure. To recap the salient points, hemolytic and ghost cell glaucoma can occur following vitreous hemorrhage. In hemolytic glaucoma, hemoglobin-laden macrophages block the trabecular meshwork, and these hemoglobin-laden macrophages may be detected in the anterior chamber as red-colored cells. In ghost cell glaucoma, dehemoglobinized red blood cells which are stiff block the trabecular meshwork. The degeneration of red blood cells to ghost cells can take 2 weeks to 3 months to occur following a vitreous hemorrhage. The cells in the anterior chamber and the vitreous hemorrhage appear as tan or khaki colored in ghost cell glaucoma. Treatment of hemolytic and ghost cell glaucoma is clearance of vitreous hemorrhage and lowering of the intraocular pressure with medications or surgery as required. Schwartz-Matsuo syndrome is elevation of intraocular pressure following a rhegmatogenous retinal detachment. Photoreceptor outer segments in the subretinal space can enter the vitreous cavity through the retinal brake and may ultimately block the trabecular meshwork. Treatment of Schwartz syndrome is reattachment of the retina and IOP lowering as required. Steroid-induced glaucoma occur in steroid responders following ocular or non-ocular administration of steroids. Ocular administration of steroids have a higher chance of increasing intraocular pressure as compared to non-ocular administration of steroids. The rise in intraocular pressure following steroid administration occurs due to increased resistance to aqueous outflow in the trabecular meshwork. Risk of steroid responsiveness increases with primary open-angle glaucoma or family history of primary open-angle glaucoma, myopia, very young or old age, type 1 diabetes mellitus, and connective tissue disorders. Lower anti-inflammatory potency topical steroids such as fluorometholone, remexolone, and loteprednol cause a lower incidence and a lower degree of intraocular pressure rise as compared to higher anti-inflammatory potency topical steroids such as dexamethasone, prednisolone, difluprednate, and betamethasone. Before administration of depot steroids such as periocular or intravitreal injections of steroids, response to topical steroids should be assessed. Following initiation of steroid therapy, IOP should be monitored at appropriate intervals. Treatment of steroid-induced glaucoma includes withdrawal of steroids if possible and IOP lowering as required. Thank you for listening.